All right, let's get into it. Non-invasive positive pressure ventilation. All right, so as always, I don't have any disclosures, but I'm always looking to get paid to shill snake oil. So if you know of anybody who is looking for snake oil salesman, I might be that guy. So we're going to talk a little bit about the anatomy and physiology of airway, how non-invasive positive pressure ventilation works, the indications for it, contraindications, complications, what some of our evidence is, and then what does our protocol say about this stuff. So just to refresh everybody's memory, this is what your upper airway looks like. And your upper airway extends basically from your lips and nose down to the vocal cords. Okay. And vocal cords sit right in here. Okay. So you've got your tongue, you've got your nasopharynx, you've got your oropharynx, and then you've got your epiglottis here. This is your vallecula. I'm not using pointer, am I? So you guys can't even see what I'm pointing at. Here we go. So this is your vallecula right here. That's when you're using a Macintosh blade. That's where the tip of your blade is going to go. If you're using a Miller blade, you're going to be touching the tip of the epiglottis right here and lifting this whole thing forward. Okay. If you're using a King airway, the King airway main balloon is going to inflate right here. Okay. Or it's supposed to inflate right here. And then the esophageal balloon will inflate down here. If you're using an iGel, the iGel gel part is going to seat right in this area here. Okay. That way it occludes a little bit of the esophagus, and it occludes above it, so that way air can go through and down into the airway. Okay. For your lower airway, that's from the vocal cords down to the alveoli. And there's a couple of important pieces that you need to remember, which is the trachea and the bronchi, basically the tubes. Okay, so you've got your trachea, and then you've got your bronchi that then branch out into the various lobes. Okay, you've got your bronchioles, which are the very small little tubes. Okay, that eventually then lead down to the alveoli. And remember that the alveoli are the small little sacs that actually do the gas exchange. So that's where all the magic happens, is down at those alveoli. So this is what your alveoli look like. You've got connective tissue kind of surrounding all of it to provide some structure. You've got the sacs themselves, which are fairly thin, along with ductwork that then carries both the gas as well as blood supply in. And the outside of these air sacs is wrapped in this capillary membrane. So we're trying to maximize the surface area of the alveoli, so that way the gas exchange can occur on a large scale. Okay, so every breath that you take, these are expanding and contracting. Okay, and then the gas is able to be exchanged across them. So here's what's happening right at the capillary membrane. You've got red blood cells that don't have oxygen that are coming in, gathering oxygen from the capillary membrane airspace, and carbon dioxide is then going outward and going away from the red blood cell. This particular graphic here is actually at the tissue level, so this is out like in your muscle, etc. But it gives a pretty good explanation of how this gas exchange is happening. So you're losing these carbon dioxide molecules at the same time you're gaining the oxygen molecules. So how does this work? So this is all basic airflow. Okay, it's just a series of pipes. Okay, and one of the things that we want to try and do is maximize the amount of airflow that is able to occur. So laminar flow is when the air is moving slowly, and that's when you have normal lung sounds. So you've got, a nice wide open pipe, and all the air is traveling essentially in the same direction. Okay. You then get into transitional flow, which means that there's some turbulence now being introduced. So we've now gone from laminar flow out to this transitional flow where the air is kind of being shunted in multiple different directions. Okay. And then we've got fully turbulent flow, which is where everything is, kind of bouncing around, and there really isn't as much straightforward motion as we'd like to see. Okay. So there's a couple of things that will cause this. Obviously, just inherent to our anatomy, we've got to split the air off into the various different bronchi and the bronchioles, et cetera. So we've got that built in. There's not a whole lot we can do about that. However, when our airway swells, like with asthma or allergic reactions, et cetera, or we get lots of mucous membrane mucus production, that's going to contribute to this transitional flow and turbulent flow. Okay. So as this airway that's nice and free flowing begins to swell, it's going to introduce some turbulence into the system. So that's one of the things that will begin to cause wheezing. Okay. Air is moving differently, like across a whistle. And so it causes this wheezing. And one of the things that we try and do with non-invasive positive pressure ventilation is to hopefully get this turbulent flow smoothed out somewhat. It's also why we use albuterol to open the airway more, dilate that bronchiole. That way we have more room to do airflow through, and why we also do ipratropium or Atrovent. Okay, the second half of Duoneb. That tells the mucous membrane stop producing as much mucus, dry up, so that there's less mucus plugging that can actually occur. So again, this is, lung expansion, inhalation, and expiration. It's a multifaceted approach. So we all rely upon our diaphragm in order to breathe, but we also have to rely upon the intercostal muscles, and in some cases, our accessory muscles like our scalenes and our trapezius as well, to help us breathe if we're in respiratory distress. But the main things that we rely upon are our diaphragm contracting. And remember, it's this big floppy muscle, okay? And when it contracts, it's going to tighten up. So it's similar to taking a rubber band, and if you tighten it, it's going to flatten out like that, okay? So that's what we're hoping to have happen. And then the intercostal muscles will also begin to open up, allowing us to get air in. So as we generate negative pressure in here, it then allows airflow to come in, okay? And then when we exhale, diaphragm relaxes, intercostal muscles relax, okay? We've now got a relative positive pressure inside of our chest, which then means the gas is going to go out to the lower pressure area, okay? When we do non-invasive positive pressure ventilation, though, we're turning this on its head, okay? So instead of us having a negative pressure here, we're always going to be maintaining a slight positive pressure inside the chest, okay? And what that allows us to do is it allows us to keep those alveoli that normally are going to shrink with every breath, okay, and in some cases collapse. We allow them to stay a little bit open. And the idea behind keeping them a little bit open is that then means that they're not going to get stuck closed. Because if we've got somebody who, is having an asthma exacerbation or an allergic reaction, again, they're going to have tons of mucus that's being produced, okay? And mucus is sticky. We don't want stuff to be super sticky. And so by keeping this area slightly open, we don't give a chance for that mucus to actually stick, okay, and keep that thing closed. Same thing with congestive heart failure. If we've got alveoli that are partially filled with fluid from the congestive heart failure, one of the things that we can do that will influence this is by having positive pressure there. There's thought that positive pressure allows that fluid to basically be on the inside of the balloon, evenly distributed, as opposed to pooled at one section of the balloon that then collapses on top of it. Okay, so we hopefully keep that membrane open, allowing it to do gas exchange more easily. So There are a bunch of different kinds of positive pressure ventilation. A lot of EMS will use this oxygen in demand positive pressure ventilation, and that's what you guys use. So it's powered by your oxygen tank, and it's providing extra oxygen under pressure from that tank. So essentially, we're using the pressure that's contained within there to actually provide the positive pressure to the person. It's not really truly CPAP, since there isn't a ton of pressure at the end of exhalation. Okay. So once we've gone out, there's not a ton of pressure actually left within the chest. Okay. So it's not a true on CPAP, but it's pretty close to CPAP. Okay. Whereas CPAP, which is continuous positive airway pressure, these are machine powered, and they do make portable CPAP machines, et cetera. But they're on the order of thousands of dollars and require lots of maintenance, et cetera, which is why EMS has gotten away from using them as much. It's just simply still cost prohibitive to a certain extent. Hold on, let me admit. Okay, there we go. The nice thing about CPAP is that it does provide a continuous pressure. So the motor that's within the CPAP machine is going to spool up and down, up and down, up and down to maintain the same pressure throughout the entire course. So it's, if you inhale real sharply, it's going to provide, extra flow to keep that pressure consistent. Okay. And when you begin to exhale, it's going to turn that pressure on that motor down a little bit. So that way, it, again, maintains this continuous pressure across you. So this is something that a lot of people will use when they have sleep apnea, because it helps splint open your upper airway. And to a certain extent, it helps splint open your lower airway. These are generally done at lower pressures than BiPAP, which is the next thing that we're going to talk about. So a lot of people will feel that this is more tolerable than a BiPAP, because BiPAP is going to be at a high pressure and then a low pressure, a high pressure, then a low pressure, a high pressure and a low pressure. This is continuous. So they feel like it's easier to exhale across because it's the same pressure they were just inhaling. Okay. BiPAP is bi-level positive airway pressure. This again is machine powered and provides a higher inspiratory pressure. And the idea behind that is we want to try and get the lungs expanded as much as we can with as little work as possible. So the machine can actually sense when somebody begins to take a deep breath, and will spool up the pressure. So that motor will kick up and provide additional pressure. One of the common settings that we'll use is 12/8. Okay. So CPAP, a lot of the time will be between 5 and 8. Okay. The oxygen demand ones are usually supposed to be around 5, sometimes can go all the way up to 10, but it's really closer to 0 to 5. Okay. Whereas with BiPAP, we're spooling up that motor so that there's extra pressure when it senses that you're inhaling. So that way, essentially, your machine is helping bag you almost. Okay. It's providing extra pressure to you while you're opening your airway up, so that you just have to trigger it, and it's going to help expand your lungs along with your diaphragm and your intercostals. However, when you reach kind of your maximum, as you begin to exhale, the machine senses that as well. It senses that there's now a positive pressure behind it, and is then going to spool the motor down so that it's easier for you to actually do your exhalation. Because trying to push against somebody at those high pressures can be, really tiresome, et cetera, and not be very comfortable. So it spools the pressure down a little bit, allowing you to exhale more easily. So this is a pretty good example of what's happening. Okay. So during inhalation, you've got 15 centimeters of oxygen or 15 centimeters of water pressure. Okay. plus the negative 15 centimeters that your diaphragm is generating. So you're getting actually 30 centimeters of water pressure, actually pushing the airway open. Okay. When you go to exhale, then your diaphragm is exerting a positive pressure, okay, to try and push the air out. However, you still have a residual pressure being provided by the machine. Okay. So in this case, we go down to a negative 3 centimeters of water instead of a positive 8, if that makes sense. So that way there's still a little bit of pressure, across that membrane to keep it splinted open. Okay. However, if we paralyze the diaphragm, now we're left, we only have 5 centimeters. So if somebody is not breathing very effectively, it makes it a lot easier for them to inhale as well as exhale. So why would we use this? Well, obviously we use it most commonly for respiratory distress. And that respiratory distress can be from asthma exacerbations, COPD exacerbations, allergic reactions, pulmonary edema. We can also use it to hopefully forestall somebody going into respiratory failure. If we get somebody before they've gotten super tired, et cetera, we can then hopefully prevent them from progressing to the point where they just simply can't breathe anymore, and we need to now bag them or intubate them. This is also beneficial if we've got somebody who, despite us having them on maximum oxygen flow, is still having a low pulse ox. And the idea behind it is we're going to recruit some of those alveoli that have already collapsed and gotten sticky. Okay. So by us putting them on continuous positive airway pressure of some sort, whether it be CPAP or BiPAP, some of those alveoli that have already closed off and gotten stuck together, with enough time and enough treatment, are slowly going to begin to pop open. We call that alveolar recruitment. So we're recruiting new alveoli to actually do the gas exchange. So we have somebody that we've got on non-rebreather oxygen, they're still not coming up enough. If we put them on CPAP, hopefully then we're going to be able to recruit some of those alveoli that can also then participate in gas exchange and allow that oxygen level to then come up. So why wouldn't we use this? Well, if we've got somebody who's not breathing, again, these machines, especially the BiPAP ones, are reliant upon you actually breathing. That's how it knows to dial up and down the pressure. With CPAP, it's just providing the continuous pressure. It's just like sticking your head out of a window going down the highway at 55. You're going to get a continuous rush of air, and it's not going to be high pressure or low pressure. So yes, while your lungs will be somewhat open, it's not going to do much in the way of exchanging that gas in that gas column back and forth. We don't want somebody who's unconscious or nearly unconscious to do this, because there's a certain amount of this that has to be tolerated. They've got to be able to keep their airway open. They've got to be able to follow some directions. Somebody who's significantly altered isn't going to be able to do that either. So somebody who's confused, constantly grabbing at the mask, et cetera, some of that confusion may be because of their hypoxia or because of their hypercarbia, and they're kind of already past the point of us being able to help them significantly with CPAP or BiPAP. Obviously, somebody who's vomiting, it's not a good idea to have them on this. One, it all gets contained in the mask, okay? And two, it's generally poor form to shove vomit back into someone's airway. And that's essentially what CPAP or BiPAP would do, is it takes all that stuff that they vomit into their mask and begins to push it back into their airway. So as soon as somebody vomits, we need to get that mask off of them, get their airway cleared out, et cetera, and regroup and figure out what exactly it is that we're going to try and do. They do have now, this whole COVID pandemic has allowed us to see what the rest of the world does. The Europeans have actually started using essentially, it's almost like a garbage bag over the head. And so literally it's a clear plastic bag that has a gasket. You pop it on like a hat, and it's got tubes that come in the back of the plastic bag, and that's where the positive pressure is actually provided, is into this bag. So they have this inflated bag over their head that allows them to provide the CPAP and BiPAP. And so there's some initial literature that says that that may actually be better than the face mask. People that are claustrophobic seem to tolerate these balloon or helmet CPAP devices better. And it also carries less of an aspiration risk than the masks do, because if they vomit, it just goes into the bottom of the bag instead of being held right up against their airway. A couple of the pictures that I've seen of these, ICUs with this, it's funny because it looks like it's a sci-fi convention with all these people lined up with these, balloons inflated over their heads, just sitting there, in the intensive care unit. For the same reason that we shouldn't use this in vomiting, we shouldn't use this if there's active bleeding of the airway. Again, because we're now going to be providing positive pressure that's going to push that blood back into the airway, despite them coughing, etc. Obviously, if they've got any significant facial, neck, or thoracic trauma, this can be bad. So if somebody's got multiple fractures of their face, etc., then there's going to be air leaking into places that air is not supposed to go. So if somebody fractures, for example, their sinuses from an auto accident or something like that, unfortunately, that means that those sinuses are now open. The bone can now conduct air. The tissues can get dissected away, and so people will literally inflate their face. Okay, it's the same reason why we tell people that have facial fractures, don't blow your nose. The same thing's going to happen. You blow your nose once, and now you've got all this air that has dissected into your soft tissue. It's a very creepy thing. The first time I ever saw it was a guy who his tracheostomy was supposed to be closing. Well, he got bronchitis while he was healing up from it. So we had already removed the tube. The hole had gotten pretty small at this point because we're trying to get it to heal closed. Well, he got bronchitis and started coughing like crazy. And the guy had literally subcutaneous emphysema of his whole head down into his chest and everything, from all the coughing he was doing. And I distinctly remember as a medical student, he had air in his upper eyelids. You could literally feel the Rice Krispies of his upper eyelids. It was rather creepy. Again, somebody who's got significant neck trauma, if they've got, an open wound between the trachea and the outside, all we're going to do is be shoving air, out that hole, in addition dissecting away, any of the tissue here with air. Same thing with thoracic trauma. If somebody has a pneumothorax or a gaping chest wound, etc., this is going to provide potentially too much pressure, which is going to then potentially damage them. Sometimes that's what we're left with at the hospital, but a lot of the time, if we've got somebody who is that sick, we would prefer that they be intubated as opposed to being on CPAP or BiPAP, simply because we can control things way more intimately when they're on a ventilator than we can with a CPAP or a BiPAP. So what are the benefits of this? Well, it makes it easier for you to breathe. Okay. Again, it's being provided under positive pressure. So you just have to really initiate the breath, and the machine is going to help with a lot of it. It also reduces the left ventricular afterload. So again, we're changing pressure within the chest cavity as part of this. And so what happens is, because that chest cavity is now under positive pressure, as soon as the heart is done contracting, okay, and it's now going to refill, all the blood that's in the aorta has pressure still being put on it by the lung tissue that's now under positive pressure. And so it's going to squeeze that blood out of that thoracic cavity to a certain extent, making it easier for the heart to actually work. Again, we also have recruitment of some collapsed alveoli. So some of the alveoli that are not functional, we hopefully are going to begin to get functional again. It's going to redistribute the fluids on our airways. So if we've got somebody who's got lots of rowels in the bases, hopefully that will begin to open up some of those alveoli, redistribute that fluid, one, so that we can get better gas exchange, but two, by improving the kind of the surface area of the alveoli, hopefully that fluid can get reabsorbed back into the bloodstream so that we can get it peed out, since obviously we can't, just go down with the small catheter and suck all of it out. It obviously typically will improve their oxygenation. We know definitively that this reduces the need for intubation. Literally, this is something that we can fix in the field. And I love it because we're intubating far less now than we used to, because we're not letting people get so sick that they need to be intubated. I love it when a crew brings in somebody on CPAP or BiPAP, because that invariably means that, they aggressively treated this with bronchodilators and with airway stuff. So a lot of the time it may be they only needed the 20 minutes or so of EMS, CPAP, or BiPAP, and you've fixed the problem enough that just with a little bit of support, as opposed to big support, I can get them back down onto nasal cannula oxygen very quickly. Honestly, some of the time I've had to fight against the service that's going to be admitting them to the hospital. I've had to say, look, this person was on, CPAP or BiPAP for EMS, and they were, probably needing to be intubated if they hadn't put them on this, and they fixed them enough that, I haven't had to have them on CPAP or BiPAP, but they still were sick enough that they needed it. It's just EMS did such a good job of fixing them that now they don't need it. I think we've all probably had an experience where we've got the bad COPD or et cetera, that's, tripoding, thinks they're going to die, et cetera. We put them on CPAP or BiPAP, give them some breathing treatments, et cetera. And by the time they get to the hospital, they're like, oh my God, I feel so much better. They're talking, they're more comfortable and relaxed, et cetera. That's a real gratifying thing. We know that this decreases mortality. Again, once we intubate somebody, we've completely changed how they're breathing, because we've essentially taken over that act. And the longer we have somebody on a ventilator, the higher their chances of pneumonia are, along with other things. By putting somebody on CPAP or BiPAP, they're still awake. They're not needing sedation. They can still cough and clear their airway out. And they can still get up and move around some. Somebody who's sedated on a ventilator, we physically have to turn them. We've got beds that will rock back and forth and up and down and things like that. They're totally dependent on us to provide them care. Somebody that's on CPAP, they can scoot around. If their butt's getting sore, they can scoot around a little bit to make things better. We also know that this decreases the number of days that somebody is going to spend in the intensive care unit. Again, we intubate somebody, they're probably going to be on that ventilator for a minimum of 24 hours. And then we've got to wake them up enough that they can begin following instructions. But some people begin to panic as soon as that sedation begins to come off. And so what do? We resedate them and try again later. And so this can lead to increased days in the intensive care unit until we can get that person to a spot where we're confident that they're going to be able to, breathe on their own again and tolerate it. With CPAP BiPAP, it's all right, let's give you a trial. We'll take the CPAP machine off and give you a trial on, humidified oxygen or something like that. And if you're not doing well, we just put you back on CPAP, but you're awake the whole time, you're talking the whole time. We typically will do breaks so that people can eat and drink, et cetera. And so people are a lot happier as well. So some of the complications that can occur is obviously if the patient doesn't tolerate it. And I've seen this most commonly with people who are a little bit altered to begin with. So they're a little hypercarbic, just hypercarbic enough that they're going to argue with you. Or they have significant, claustrophobia and or anxiety. Because it is a weird sensation. If you've never been on one of these things, it is a weird sensation. And again, the closest analogy I can give is, you sticking your head out of a window on the highway, getting that rush of air into you. It's a very similar type sensation. Unfortunately, a lot of the time, some of these folks will say that they're suffocating. And the reality is they're already, in pretty bad extremis when we're putting them on the CPAP or BiPAP. So they're essentially already, suffocating, but then they feel like this thing that we've put on their face is making it harder for them to breathe, when in reality it's making it a little bit easier. It's a weird enough sensation that they think that we're actually suffocating them. Sometimes people will develop a pneumothorax. That'll happen in trauma patients. It'll also happen in COPD patients that have, a little bleb on the outside of their lung that will pop. Obviously, if that happens, we have to treat it. If it looks like it's developing a tension, then we've got to decompress. Aspiration is a real concern. If we've got somebody who is a little bit pukey, et cetera, that can be a real concern. Or they're not awake enough, to keep their airway clear. The saliva that they normally would be swallowing, et cetera, is just going to get shoved down into their lung tissue, unfortunately. Somebody that's hypotensive, this can also be somewhat dangerous. And the reason that we worry about that so much is we've got somebody who's hypotensive, which means that they're probably, somewhat volume depleted. So just like the positive pressure in the chest will shove the arterial blood flow out, okay, help reduce some of that afterload on the heart. It also prevents the venous blood from returning from our head and from the rest of our body. That venous blood is not under very much pressure at all. And so a lot of the time we will see people's blood pressure drop just a smidge when we put them on this, even if they're not hypotensive. But if we have somebody who is kind of borderline, et cetera, that added pressure in their chest means less blood flow returning back to the heart. Less blood flow means less for the pump to actually push around, which means lower blood pressure. So that's why somebody that's kind of a little bit borderline on their blood pressure, we usually will have to give them a little bit of extra fluid to keep that blood pressure up, so that we get enough blood flow returning to that right side of the heart. In end-stage COPD patients that are on this for a prolonged period of time, this can worsen their respiratory drive. As we've talked about during previous lectures, the COPD patient becomes a little bit more reliant on their oxygen demand. Okay, so most of us are breathing right now based off of the pH in our blood. As carbon dioxide builds up, our pH goes down, our body says, oh, hey, there's too much carbon dioxide, I better take another breath. Well, end-stage COPD patients that are chronically retaining carbon dioxide, that's out of the window. And so they're completely relying on the backup system, which is oxygen level. So if we have somebody that we now all of a sudden take them to 100% oxygenation, in some of these end-stage COPD patients, if they're on this for a long period of time, they'll lose that trigger because their oxygen level is at 100%, which it never is. And so they'll slow their breathing down and become, hypercarbic again, meaning too much CO2 has built up in the system because they're not being triggered to breathe well enough. That's really the kind of thing that we see if somebody's in the intensive care unit for a long period of time, is sometimes they will worsen, in which case we then just simply have to intubate them, unfortunately, and control their breathing for them. So what evidence is there? So there was a study done a few years ago that showed that non-invasive positive pressure ventilation in acute pulmonary edema reduced mortality 43% and reduced intubation by 57%. There is this theoretical possibility that was originally published when this stuff was all brand new of, this stuff causing MIs. That's been completely debunked now. We don't worry about an MI being caused by CPAP or BiPAP because it just doesn't happen. If somebody's going to have an MI, they're going to have an MI regardless of whether they're on CPAP or BiPAP. There was another meta-analysis done a few years after that that showed almost a 60% reduction in mortality, and it reduced the need for intubation by 40%. So huge benefit to the patient, huge benefit to the hospital, because that's one less intensive care unit bed or ventilator that we need. Another study showed reduced mortality, reduced intubation, and improved their respiratory rate and the score that they developed that tells somebody how short of breath they really are. And then finally, Kozlowski showed that it improved their pulse ox as well. So we really have some good quality studies that say that this truly is beneficial for the patient. It lowers costs as well for the healthcare system, and especially, you know, right now during this COVID pandemic, it really does allow us to preserve some of those ventilators. Without CPAP BiPAP and one of its sister products that really hasn't made it into EMS, which is high flow nasal cannula oxygen, we would have been sunk during December and January. We would have had a lot of patients that would need ventilators, and we wouldn't have had enough ventilators to take care of them. But because we have these other airway things, we can hopefully reserve some of those ventilators, you know, for even sicker patients, because we don't have to put everybody on a ventilator. So T709 is the protocol that deals with this. It's the acute respiratory distress protocol, and it's due to congestive heart failure or asthma. So you've got to have 2 or more of the following. You've got to have a respiratory rate of greater than 25 breaths per minute. You've got to have retractions, accessory muscle use, or fatigue. You've got to have an oxygen concentration of less than 94% at any time. Sometimes their lung exam will have wheezing, rales, diminished breath sounds, depending on what is actually causing their respiratory distress. And if they're in a DNR, if they're a DNR, you still can do CPAP and BiPAP for comfort reasons. So we're not using it to resuscitate them at that point, but it's to keep them comfortable so they don't feel that oxygen starvation, et cetera, that will come at the end of life. So you've got to have 2 or more of the following. So you've got to make sure that you are talking with your patient. Even patients that say, you know, doc, I've tried this in the past, I'm claustrophobic, I can't do this. You know, really work with them, coach them that this is what you need to do. You know, I'm going to talk with you. I'm going to be right here with you. And I usually will bargain with the patient and I'll say, you know, give me 5 minutes. If at the end of 5 minutes, you're still freaking out, we'll take it off. Okay. But this will prevent you from being intubated. And, you know, unfortunately, a large percent of the patients that have bad COPD where they need CPAP on a regular basis are going to have been intubated at some point. And a lot of them would much rather deal with this than being intubated again. So make sure that you're coaching them. In addition, you can do Versed 1 to 2 milligrams IV every 5 minutes to a maximum of 10 milligrams to hopefully reduce their anxiety. But keep in mind that as you increase the amount of Versed that you're giving them, that is also potentially going to impact their breathing drive. And so you may need to actually, you know, switch to bag valve mask ventilation if you make them too sleepy. Make sure that you're reassessing your patient's vital signs every 5 minutes, again, because the blood pressure will sometimes go down. And so you may need to initiate a fluid bolus if their blood pressure continues to go down. So if they're improving, then we're going to continue the CPAP until we get them over to the hospital. I highly, highly, highly recommend that if you've put somebody on CPAP, you leave them on CPAP until you're in the hospital and the hospital says, all right, we're ready to switch them over to either our machine or they look good enough now that we'd like to trial them back on non-rebreather, you know, oxygen, et cetera. If their status deteriorates while you're still transporting them, unfortunately, sometimes you've got to discontinue the CPAP and evaluate whether or not this is something that you can just bag, or if this is somebody that we need to now begin to intubate. As soon as we know where we're going, if we've got somebody that's on CPAP, please notify the destination hospital early, because that will allow the respiratory therapist to come down, get the CPAP or BiPAP machine set up. So that way, as soon as you guys get there, they can get switched over to the hospital machine. Once you get to the hospital, it really is up to the ED physician to determine whether or not this person can be discontinued off CPAP or BiPAP. So I would really highly encourage you to kind of stick your ground. If you've got somebody that's on CPAP and they're doing well on it, you know, even if the nurse is like, no, I really want to take it off, that's when it's okay to say, look, you know, our protocol says that the physician is really supposed to be the one who determines that. So go grab them. Hopefully, most of the time, these patients, you're being met by the physician in the room fairly shortly after their arrival. So that way you don't get into a situation like that. You can use a nebulizer with these, and I love using nebulizers with CPAP BiPAP because we're using that aspiration risk to our advantage. This is going to drive the nebulized medication in even more deeply into the lung tissue, so that we're getting the albuterol and ipratropium down deeper into the lung. Most of the CPAP devices that EMS carries already have, you know, the tubing and whatnot included. I can't remember off the top of my head whether or not ours do. I think they do in the same baggie, but it'll usually require a T-piece like you see in the picture here. And then the T-piece allows you to hook the nebulizer cup up. Now, the downside to the oxygen powered ones is that you've got to have another port for you to be able to give the nebulized treatment on, in addition to, you know, running the CPAP machine. So this is one of those situations where if you're on a portable tank, I really would put them on CPAP and get out to the truck before I would try and do a nebulized treatment. You're going to burn through that cylinder so much faster, and you may not have enough ports to actually do it. You can do capnography with this, and we're going to talk about it here next. But you can do this. However, you've got to make sure that the nasal cannula for the capnography that we use is on, and you're not getting significant leakage kind of around the edges, since now you're going to have this nasal cannula prong underneath your CPAP mask. You've got to make sure that you're not getting significant leakage around where those small tubes are exiting from the sides. You can't use the inline sensor that we would use if we had intubated somebody. You can't use that because the gas isn't being exchanged that way. You can only use the nasal cannula type prongs. All right. Questions on CPAP BiPAP?